hearing people to teach us. So please take it away.
Keita, thank you. Appreciate the opportunity for the Ombudsman team to be able to speak with your membership this afternoon, maybe learn a little bit more about the program. So thank you so much. Amos, if you could advance us a couple slides. There we go. And then great. Thought we'd just start with the overall mission, which is pretty simple. You know, we serve as an advocate and resource for older adults and persons with disabilities that live in long-term care facilities or receive services in their own homes through the Medicaid elderly and persons with physical disabilities waiver, with the goal of enhancing their quality of life and quality of care. So it's a pretty simple mission. Two things I do want to mention, though, for your members. We're authorized under the Federal Older Americans Act. We're also designated by Health and Human Services as a health oversight agency, which means we're exempt from the HIPAA privacy rule, which allows us to have access then to individuals and their records in the event that they cannot give us permission and they do not have a legal decision maker available to them. So the other thing is we're not mandated reporters of abuse, neglect, or exploitation. And that surprises some people, but that allows us and it reassures the residents confidentiality, which is really the cornerstone of our program, that there's a trust relationship with the residents so they can tell us anything they want. We're not going to take action unless they give us permission to do so. Amos, next slide. Thank you. Just a real quick overview of the people we serve. There's 17 nursing homes currently in the district, 16 assisted living facilities, 90 plus, that's kind of a fungible number of community residence facilities. Those are the small group homes operated and licensed through the Department of Behavioral Health. And then also EPD waiver clients, more than 5,000 of those. And I have to say that in the district, we're one of 11 or 12 states that have the additional authority for investigating and assisting people that are receiving services in the community. So next slide, Amos. I thought this would be helpful to put up because I think oftentimes people think of us as only investigating complaints and just we're always there. And if you noticed on the couple of first slides, our tagline is educating, empowering, and advocating. Really, I see a lot of our work as educating people as to what their rights are, helping empower them either individually or through resident councils, as an example, so that they can represent themselves, give voice to their concerns and problems. So the first thing that happens if somebody calls us with a complaint or a concern is we're not going to run right out to your facility. We're going to ask, you know, who have you already talked with in the facility and try to point them in the right direction, give them the information and support they need so that they can address issues themselves. And just as a side note, that makes it very important for you as providers to make sure that your grievance process is front and center so that people know who to talk to when they have an issue or concern. So I just thought that it's important to bring up. Like I said, a lot of the work that we do is providing information to individuals. Many individuals come to us that have never had to navigate the long-term care system before, and so we kind of help them do that. We also provide support to resident and family councils, advocate for systemic changes where needed. One of our I think real accomplishments of last year was we were able to advocate to get residents an increase in their personal needs allowance from $70 to $100 a month with a built-in COLA. So very, very proud of that. We're trying to provide a regular presence in facilities so that not only residents get to know us, but that providers and staff get to know us so that we have a positive working relationship. We also train and support a core of about 25 volunteers currently. So it just kind of gives you an quick overview of kind of what we do. Almost next slide. If you click it again, right. Just a couple things, kind of by the numbers. Last year we investigated and closed 169 complaints, and we're able to resolve 86% of those to the satisfaction of the resident or the complainant. It's a very high resolution rate, one of the highest in the country. Handled 713 requests for information. Again, those were people that contacted us, had questions about where a facility is located or how do I apply for Medicaid, all those sorts of questions. We worked and attended 135 resident council meetings and 8 family council meetings. I'm going to mention our priorities in a second about that. An important number, 104 requests for information and technical assistance from providers. Providers reached out to us with an issue. Oftentimes it deals with discharge or care-related issues, and we're able to step in and provide some assistance there. And 84% of our complaints are from folks that are either on Medicaid or are dual eligible. Next slide. Just really quickly, the most frequent types of complaints, and this is across all settings, discharge and eviction. It's our most frequent complaint. It's also been the most frequent complaint that ombudsman programs receive nationally for probably the last 5 or 7 years. Staffing related issues, I think we can all understand the challenges there. Response to requests for assistance, that's where someone might press their call bell and need to go to the bathroom and having to wait a long time for assistance. Access to health related services, billing charges, and then rights and preferences. So those are the kind of the top complaints across all venues. Next slide, Amos. Just a couple of quick trends, and obviously we could spend an entire afternoon talking about any one of these. Certainly we see an increasingly diverse resident population, and of particular note, both in the district and I think nationally, we're seeing an increase in the number of residents that need long-term care services that also have a mental health issue or a substance abuse issue, making it much more difficult and challenging sometimes to provide appropriate care. But we're seeing that, and we're seeing a greater diversity amongst the resident population. Certainly a growing demand for affordable assisted living. I think the district has made great strides in this effort, and also the home and community-based service options. Workforce issues, that's the staffing piece, a huge challenge, I think. Turnover rates are big everywhere. So those are one of the, that's an ongoing trend. We've seen that for many, many years. We're hoping that that gets addressed soon through CMS regulations on minimum staffing standards. And then overall, the lack of capacity to meet the demand for services, particularly with regards to nursing facilities. Since I've been here the last 7 years, we've lost more than 430 beds. Those beds haven't been replaced. Unfortunately, then that means people wind up having to utilize facilities outside of the district, primarily in Maryland. So those are some of the trends. Almost next slide, and this is, I think, my last slide. Just our priorities for the coming year. We've been involved in 2023 with outreach to underserved populations, particularly focused and targeted on LGBTQ community, developing some materials, doing some presentations regarding their rights, and I think some of the staff will talk about that in a little bit. Development of family councils, that's a priority for us this year. Last year, we developed 2 new resident councils in assisted living, very proud of that, but now we want to also focus on the family councils. Passage of the Electronic Monitoring and Resident Protection Act. Some of you may be aware of this. This pertains primarily to nursing facilities that would allow at the residents' or family's expense to be able to put in a monitoring device in a residence room. And finally, priority for us is increasing the availability of affordable assisted living. When you look at it nationally, there's very little available, and that unfortunately impacts many people. And so if you can't stay at home, you don't have affordable assisted living, you wind up going to a nursing facility. So we're hoping to encourage an increase in affordable assisted living. And with that, I'm going to stop because I've probably gone over my 9 minutes. There's our contact information, and Nikita, maybe we can put that up again at the end so people know how to reach us. So I will hand it off to Purley Jones, our Ombudsman Program Manager.
Thank you, Mark. Great overview of our program and giving us a high-level view of what's happening nationally. I'm going to talk a little bit about the assisted living residences within the District of Columbia. I've been with the Office of the Long-Term Care Ombudsman for 8 years now, and I've always focused on assisted living and have, really been able to celebrate the growth of affordable assisted living for our District of Columbia residents. The District of Columbia Department of Health, the Health Regulation and Licensing Administration licenses all of the assisted living residences as well as the adult homes in the District of Columbia. The adult homes are very similar to assisted living. However, the assisted living tends to have a higher level of care. The district, as Mark said, has 17 assisted living residences thus far, 9 of which are private pay, and 7 now are Medicaid EPD Waiver supported with public financing. So what is assisted living? It means it's an entity, whether public or private, that combines housing and health services and personal assistance in accordance with the needs of the individual resident. And so services are provided on a person-centered basis, meaning prior to a resident coming in, there's an assessment done 30 days prior to the admission, and it is a review of all of the medical documents, rehabilitation, and psychosocial information, and then the facility itself conducts its own assessment of the individual's functional capacity. And then a preliminary ISP or individual service plan is developed. And then 30 days following the admission, there's another assessment conducted, and then a more sustaining individual service plan developed at that particular point. Okay, and in essence, a individual service plan includes all of the services that the individual will need. It will describe when those services are provided, how they're to be provided, as well as who will be providing those services. Just a word about the philosophy of assisted living. It emphasizes personal dignity, autonomy, independence, privacy, freedom of choice, and of course, the rights of an individual. Okay, the other concerns or challenges are making sure that the resident is in a home-like environment, that they are provided an environment that feels pretty close to home to allow them to age in place with dignity. And then services can be added or they can be reduced according to the individual's change in needs. Okay. So what's the role of the ombudsman? We're advocates for resident rights, and we monitor the quality of care, quality of life in the facilities. And then as Mark highlighted, we educate and we empower. And one of the key ways in which we empower is through the resident council. And so DC's laws support the forming and the development of resident councils, and it is a council or an association of the residents who live in either a nursing home or an assisted living community. It supports them to join and unite their voice together. And they have the opportunity to share their points of view one with another. It is pretty much like what you would call a neighborhood association, except there's no fees to participate. The role of the long-term care ombudsman then would be to attend those meetings, but only when invited by the residents. And so the ombudsman would help the residents to locate resources, would help them with promoting and advertising, their meetings and activities, help them to recruit their members, spreading the word, and then communicate with staff and family members. And there are often occasions where the ombudsman will make presentations, and getting back to that role of education and empowerment. So making presentations on specific topics that are of interest to the council members. Okay, let me just emphasize that it is extremely important that the resident councils are run by the residents. The regulations make provision for the residents to ask for the support of staff. However, the residents should be the ones who are running the councils. Okay. A word about resident rights. The law also supports the promotion of residents' rights. When individuals move into assisted living communities, doesn't mean that they leave their rights at the door. So they have, there's no limitation in their personal or civil rights. And the ombudsman is watchful to advocate for residents' rights, and they are supported in the law. The Assisted Living Residents Regulation Act of 2000 clearly enumerates those laws, and I'll state them, very quickly. It is the right to self-determination. It's the right for dignity and privacy, accommodation of needs, representation and resolution of grievances and complaints, full disclosure, the freedom from abuse, neglect, and exploitation, and notice of the residents' rights. Okay, and then just a final word. The legal counsel for the elderly has engaged its own initiative to center race, diversity, equity, and inclusion. And I would encourage all in the community to maybe find out more about the long-term care equity index, as many of my colleagues have recommended and suggested. And this would be a great way to engage and to support the efforts to make housing accessible and without bias or discrimination to our LGBTQ citizens. And so thank you very much. And I'm going to turn it over to our next speaker.
Thank you, Purley. Almost, I think you can get to our next slides. Perfect. Thank you so much. So myself and Kimberly Walker, who you'll meet in a minute, are going to have a short overview of our group homes in DC. So we refer to them as MHCRFs. And these are publicly or privately owned community residence facilities that provide 24-hour supervised care in a home-like environment. It could be a house or an apartment building. And these house individuals ages 18 or older with a principal diagnosis of mental illness who require 24-hour care for monitoring or personal assistance with activities of daily living, including meals, and who are not in the custody of the Department of Corrections. There are three principal categories of group homes designed to meet different levels of residents' needs, including what we call SRs, which are supported residences, which would have a lower level of care. A step above that are the supported rehabilitative residences, or SRRs, which have, a higher staff ratio and should be offering more services individualized to the residents who live there. And finally, our intensive residents, or IRs. These are residents with a primary diagnosis of mental health who also need greater assistance with nursing care and just need, in general, more medical support. Next slide, please. So here you can see where our facilities are located across the district. You can see a high representation in wards 7 and 8. Currently, we have about 89 group homes. We have lost some facilities and beds in 2023, so that's an issue that we continue to monitor. So let's see, next slide, please, Amos.
Okay, thanks, Nicole. All right, so the Ombudsman program receives many MHCRF complaints. However, some of our most common complaints involve care coordination issues, such as, the resident not being able to reach their case manager. There may be a change in level of care for the resident, and there needs to be a meeting held and trying to get all the support team together to talk about those concerns and those changes. Transportation coordination or medical appointment coordination are some of the other issues that may arise that the resident is trying to get resolved. So those surround care coordination issues. The next is invalid discharges. Sometimes we receive discharge notices that are invalid for the resident, not including the location of where the resident is intending to go. We got to make sure there's a safe discharge. So oftentimes we'll get notifications that are not completed correctly. In addition to that, breaking house rules, the residents sometimes are smoking in the residential facility, which is against the house rules and could be a safety concern for everyone else in the home. Also, access to personal funds. The resident may not be receiving their personal allowance each month, which interferes with their ability to purchase personal items. And also outstanding rent payments. Sometimes we get complaints about residents not being able to make their rent each month. And that could be a result of, again, care coordination from their case management team, not following up on something or not submitting the necessary paperwork. Next slide, please. All right. So as already mentioned, our program serves residents who are in nursing homes, assisted living residents, mental health community residential facilities, and persons who live in their own home and receive the elderly and persons with disability waiver. So this chart shows the number of facilities we serve in each sector and the amount of complaints we resolved. As you can see, we closed about 187 complaints amongst all long-term care facilities for 2023. Out of the 187, 47 were mental health community residential facility complaints for 2023, excuse me. In addition, we addressed 168 requests for information and consultation from providers or individuals. Next slide, please. Okay, so let's get into resident rights. So MHCRF residents are protected by the laws of the United States of America and the District of Columbia. Under these laws, residents have many rights, such as the right to have visitors at any reasonable hour, the right to make personal medical decisions and freedom to refuse treatment, the right to have mail delivered unopened, and the right to have access to a telephone or to have a private telephone installed at their own expense. So the Ombudsman program makes every effort to ensure the resident and their support team is aware of their rights by conducting community trainings, outreach events, passing out brochures, and handing out resident rights cards. We also educate during facility visits. Next slide, please.
Right, so in addition to those rights that Kimberly mentioned for our MHCRF residents, they additionally have the right to bring in any personal possessions or furnishings into their living quarters, the right to a total care plan and complete information about all the services that are being provided to them at the group home, any charges on their account, and any house rules. As Kimberly already indicated, some of these categories in particular can get very complicated and lead to, at times, discharge notices where care coordination and really coordination of services and clear communication could have avoided some of those eviction notices. Anyhow, two more. We have the right to be given advance written or oral notice before any transfer, discharge, or relocation happens. And finally, the right to be free from abuse, neglect, discrimination, and retaliation. Next slide, please. So in addition to those rights that we just read off, there are additional protections that provide for the inclusion of LGBTQ+ identifying residents. So CRFs, our community residential facilities, really must be free of discrimination based on sexuality or gender identification. And so that means that the staff really needs to ensure all privacy and respect are provided for all residents, regardless of their status, how they identify. Additionally, they must not exhibit any bias or prejudice toward any resident for any reason, but particularly included in that is the LGBTQ community. And then finally, as Kim mentioned, we really want training and education provided to staff and to residents both. If there are ever concerns about treatment, if there's ever any allegation of abuse or neglect or bias, prejudice, etc. So in addition to the rights that we'd previously mentioned, we always want to highlight that this community in particular has additional protections, and we want to make sure that they understand that we are advocating for them as well. Last slide, please.
Okay, thank you, Nicole. So here's our contact information. So if you need to reach out to us about any questions or concerns after this forum, please feel free to do so. So next you will hear from our Home and Community-Based Service Ombudsman.
Difference like go out to the community. Okay, hopefully, can you hear me now?
Yes, that's a bit better.
Okay. Walter Williams and Sheila Pinnell are the Home and Community-Based Ombudsman. The first thing we like to do when we go out into the community to assist our residents is all visitations that are conducted by the Home and Community-Based Office are to monitor the quality of life and care for the residents who receive services in their home, as opposed to those that are receiving them in a facility. We like to point out that ombudsman, people aren't really familiar with the ombudsman term. So we point out that the ombudsman is simply a fancy Scandinavian term that means advocate. We are here to advocate on your behalf with your permission. We also like to differentiate between, because a lot of folks are familiar with the Medicare ombudsman or the Office of the Healthcare Ombudsman. There is the Office of the Healthcare Ombudsman, and then there's the Office of the Long-Term Care Ombudsman, for which we are a part of. We also like to distinguish, because a lot of when our emails go out, our emails will say AARP. We're located in the AARP National Headquarters building. So what we like to let people know is that even though our grant comes through AARP and Legal Counsel for the Elderly, we are an independent office, the Office of the Long-Term Care Ombudsman, here to advocate on your behalf for your rights, to protect your rights. As Mark stated, there are about 13 states that have a home and community-based ombudsman program. It's not available in all states. So we want to make sure that the individuals who are receiving these services understand the difference between our office and the Medicare Ombudsman's office and the Long-Term Care Ombudsman's office that may be in another state. We inform residents of their rights to prevent them from being victims of any kind of exploitations. We investigate complaints against home health providers, case management agencies, and self-directed programs. We don't really step in to provide any type of assistance for the PACE program, which is a new program that just started last year. PACE stands for Program for All-Inclusive Care for the Elderly. However, we do investigate complaints that the beneficiaries bring to us with reference to home health care providers. If there's an issue with their aides that are coming into the home, we investigate those complaints and we try to resolve them to the satisfaction of the beneficiary, although that may not always be possible. We also investigate complaints from the case management agencies. So the case management agencies are those that are the first line of care for people who are on the EPD, Elderly and Persons with Disabilities Waiver. So they direct those issues that the beneficiary has in the home, and if they can't resolve them to the satisfaction of the beneficiary, then they contact the Ombudsman's office. We educate residents on their rights and protocol. We've been given their annual level of care assessments by Liberty for continued personal care, because Liberty comes out and assesses you based on what the questions that they ask, and then they will give you a level of care, which will determine how many hours of actual care that resident can receive from a home health agency. We educate and empower residents and their families, stakeholders, and significant others about residents' rights and when to request a fair hearing. So if a home health agency, let's say, sends a termination notice to the beneficiary, that beneficiary has rights and he can file an appeal through the Office of Administrative Hearing. So we help them to make sure that they can file that hearing through the Office of the Healthcare Ombudsman. And we follow through with them and go out, not to represent them sometimes, but to be there as an advocate on their behalf to help them plead their cases. We monitor and make recommendations on DC laws, rules, and regulations that will have an impact on the health and safety of residents residing in their homes. We also work as a team member with the DC agencies for the benefit of our residents. So in all, where some residents are receiving services in a residential care facility or a nursing home, we actually go out and provide those same services for individuals who receive services in their home. Next slide, please. If you have any questions, our contact number should be available also. Sheila Pinnell and Walter Williams. And if that slide is not available, we will produce that slide before the end of the presentations. Thank you. And I think our next speaker might be Albert Reed.
Good afternoon. Can everyone hear me okay?
Yes, sounds
Okay,
great.
very good. Okay, thank you. I'm not Albert Reed. You'll hear from him soon. But I'm Hennessy's Catchadon McCrimmons, and I am one of the two nursing home ombudsmen. The other one is Albert. And so we share the district's 17 nursing homes. I am assigned to 9 of them. Almost, if you can pull up that list, please. And those are that's the list of my assigned facilities. And then Albert is assigned to the other 8. And if you can share that as well, please. And he's assigned to those facilities as nursing home ombudsman. And you can go to the next slide. Thank you. So as nursing home ombudsman, and you've heard this from essentially all of our areas within our program, but I'll bring it back home again. So Albert and I promote and protect residents' rights, and we ensure that nursing home residents receive the highest quality of care and live the lives that they want to live. So we assist residents with understanding their rights, voicing their concerns, finding solutions to issues and problems, and at times, if necessary, obtain legal services. I think you heard a little bit about this, but I still want to mention it. Our responsibility in the long-term care facilities, in the nursing homes specifically, we investigate and resolve complaints on behalf of the residents and for the residents. We educate the community, much like this meeting, on long-term care issues, services, and supports. We protect the privacy and confidentiality of residents and others. We monitor and make recommendations on DC laws, and we ensure that residents' rights are protected, and that is imperative for us. And so we do that by engaging with resident councils and attending their meetings, where we often discuss residents' rights to ensure that every resident, including LGBTQ residents, knows and understand their rights, and that it is protected. And I believe Purley or someone had mentioned this under federal and district law, because we all have the right to be treated equally. And you've heard this a million times, to be treated equally regardless of race, ethnicity, sex, gender, etc. Our advocacy work also includes quarterly meetings with the residents' council officers, with the goal to empower and encourage collaboration and to give residents a strong voice in matters that impacts their rights, care, quality of life, and dignity. And so during one of our recent calls, I think not so recent, but earlier this year in May for Older Americans Month, we partnered with the National Consumer Voice to discuss overcoming barriers for LGBTQ residents, inclusion, language, and terminology, which are critical as we build comprehensive spaces for long-term care residents. Albert?
And Amos, I think you need to go down maybe one more. And thank you, Hannah. And before I dive into just touch a little bit more on the LGBTQ plus, and the reason why we're doing this because, as Mark stated at the beginning, it really is a priority for us to focus on this. But I want to just touch on one other thing that Mark stated earlier in this, because this really was a huge win for us, the increase in personal needs allowance. This was a Marian Parker attorney who helped worked on this for the last 3 or 4 years. The personal needs allowance was for years was $70, and we're talking about 35 to 40 years. So and just to recap, the personal needs allowance is what a resident will use. Sometimes they use it to buy extra snacks, but a lot of times use it for grooming purposes. And this is all they have for the entire month. So until the next month. So they may, for instance, they use $30 to $40 a female uses to get her hair groomed, and then, they have $30-something left for the rest of the month to buy snacks, to do whatever. So this was a major win to get this increase to $100. And as Hennis has stated, we were, attending the resident council meetings. Every meeting we would go to for the last 2 years, they didn't want to talk about anything else but asking us about when were you going to get, when we're going to get the increase. They didn't want to talk about, you could talk about any other resident rights. All they wanted to know about Hennis's or Albert, when we're going to get the increase. So finally, this past February, Healthcare Finance, which is DC Medicaid, made the announcement that they were going to get their increase to $100. And again, I really wanted to focus on this because this was a monumental effort by our office. And again, I do want to give kudos to Marianne Parker, who's going to be leaving our office soon. The work that she did to get this done was just amazing. Again, this was something that and again, beat us over the head for a couple of years, but finally they got that done. So I want to just focus on this as we close out here our presentation on LGBT. You've heard, as Hennis has stated, each and every one of us, from Mark to Purley, from our CRFs to ALRs to home and community base. The LGBTQ population is a marginalized community, but what you don't understand is within that marginalized community is another marginalized community, and it's the older population. So I recently went to, this just occurred a couple of weeks ago, I went to an LGBTQ housing summit. And this was hosted by a number of wonderful advocates in the District of Columbia that are advocating for advocating for affordable housing for the LGBTQ plus community. And this is for the trans, all of this. The one thing I was sort of disappointed is that there wasn't a focus on the older. And these are individuals who are trying to transition out of long-term care facilities back into the community that need not only supportive, safe communities, but they need accessible housing. So imagine this, you're not only an LGBTQ plus community population member, but you're in a trans and you're in a wheelchair and you need accessible. So you try to find a place for that person. It's almost so, it's one thing to be a 40-year-old white male in LGBT community, you want affordable housing. Try being a 70-year-old Black male or Black female in a wheelchair and you're trans. I mean, you're talking about the hurdles and the barriers are astronomical. So this is where our advocacy comes into play. This was a priority in 23, we're ratcheting it up in 24 regarding this community because we see the barriers. They're astronomical, but we are willing to make certain that, that this community, which is, we see marginalized within marginalized, that we make certain that there's a spotlight placed on this, because there is not only supportive housing needed, but accessible supportive housing needed. And finally, we don't know, when Hennis and I go in these nursing homes, we have to tread lightly. We can't go in these resident council meetings talking about, oh, we're here to support LGBTQ+. Because you know what? Somebody may be in there hiding, doesn't want to come out. And they're saying, oh, Hennis and Albert found out about me, and then now I'm going to be called out. We have to tread extremely lightly how we approach this as an advocacy, as the ombudsman. So we have a lot of work to do. And when we go in these long-term care facilities, whether it's CRF, whether it's ALR, whatever it is, we come in as partners. We don't come in as enemies. We come in as partners. As the ombudsman, we come in as partners. We teach our volunteers to come in as partners, to work together, to make certain that we advocate for everyone, for choice, no matter what it is. So again, we thank you for this opportunity on behalf of Hennis and I, as ombudsman specialists in the nursing home. Thank you.
you so much to the entire team today at the Office of the Long-Term Care Ombudsman. I know that I learned so much, including where the word ombudsman came from. So I really appreciated that. I think it's really wonderful, the advocacy that you all did to help raise the personal needs allowance for our older adults. And I also had a question, and so I'll get started with our questions about volunteers. So I believe it may have been Mark who mentioned that you all train and manage volunteers. And so I was curious about the roles of those volunteers and what needs you all might have for volunteers that we could help to share.
Nikita, thank you. Yes, good opportunity to put in the plug. We're always looking for more help. There's just not enough of us to go around. And I had mentioned briefly, what we try to do is establish a presence in every facility so that residents get to know us and who we are and feel comfortable coming to us, but also so that we can develop a good working relationship with, with the administration of the facility. So the more volunteers we have, they're kind of our eyes and ears. They're fully trained and certified. They can handle complaints as well, but oftentimes what they're doing is meeting with residents, identifying individual and systemic issues, and then bringing them back to us so we can strategize about how to resolve those issues. So right now we have a core of about 25 active volunteers that are assigned primarily to nursing homes and assisted living. But if we had more, we could certainly expand our footprint. And also in some of the larger nursing homes, it'd be easier if we had 2 or 3 people to be able to kind of cover that ground, so to speak. So always looking for more. You don't need any special qualifications. We train folks. Do have to have a level of comfort in terms of working with older adults and in sometimes conflict situations. But other than that, we would welcome anyone, and we will be having a training in February, I believe, for new volunteers.
Great, thanks so much, Mark. Just writing that down so we can share that. Are there any other questions from our attendees? I think you have so many experts at our disposal and burning questions that we may have. Though I also want to point out and highlight that thank you for sharing your contact information. It's here right up on the screen, and I will be sharing it after call as well to make sure that we all know how to get in touch with the long-term care ombudsman. The absence of
And
any... Oh yeah, go ahead.
Makeda, I would be remiss if I didn't say that there's a great respect for the fact that your role is advocacy and education, and your willingness to embrace our program and really allow us a small segment to talk to your audience is most appreciative. And we look forward to spending more time with Leading Age DC. I know you're a small staff, but your influence reaches far. And so I want to continue to encourage you to do all that you're doing and more. And we would like to definitely partner on any initiatives that you have to support our LGBTQ plus citizens in the District of Columbia. So thank you.
Thank you kindly, Mr. Jones. I really appreciate your words of encouragement and the spirit of partnership that I've enjoyed since I've engaged with you all. I do believe that the work that you do is consistent with the mission of Leading Age DC, and many in our network Many of us are mission-driven nonprofit providers and individuals who are interested in helping because we care. And I think the more that we can share information and resources, we're going to allow each other to have a greater impact working together than we could working on our own. So very, very humbled and honored to be in such great company. Are there any other things that your office might want to share? Any events coming up next year or things that we should be on the lookout for in addition to the volunteer training in February?
We have an action-packed strategic plan, none of which I can share here, but I can assure you that we're going to be touching many of the issues that we talked about. But as a part of the legal counsel for the elderly in the District of Columbia, we're going to be utilizing their legal services, and they service individuals 60 and over who are low-income residents. And we are crossing boundaries, I must say. And so stay tuned. You're going to see some great things.
Wonderful. I look forward to it. I look forward to continuing to be a partner and continuing to share information with our members and our network. I think that we can round up this wonderful learning experience. I'd like to once again thank all of the speakers for sharing your time, your expertise with us today. And I very much look forward to being able to continue our conversation and our work together. So I wish you all a happy and healthy holiday season and look forward to staying in touch.
Thank
Thank
you.
Rita.